Well, hello everyone. I hope we've got an audience, but I'll just wait a couple of minutes. Still waiting for the start time.
Oh yeah, it's 1 minute to 4.
If I was a normal citizen that normally attends...
Sandra, you're live.
All right.
Okay, we've got 61, an audience of 61 at the moment, so we might as well get going. Okay, this is the Blackheath Philosophy Forum, which is a community group in the Upper Blue Mountains, New South Wales, Australia. We, for the last few years, we've been organising public discussion forums on generally philosophical topics, but more recently we've branched out into political philosophy. And as you can see, because of the virus, we've had to be dragged into the 21st century, and we're doing our talks via live video streaming, and which has been a bit of a change, but it's actually quite enjoyable. I don't mind doing it at all. It's actually a lot less work than arranging the physical meetings. So today we're very lucky to have a guest who is a clinical epidemiologist, Dr. Fiona Stanaway, who can talk to us about the COVID-19 crisis that we find ourselves living in. And this only became available. Apologise to people on our mailing list that this was done at very short notice. We only became aware of the availability of Dr. Stanaway a couple of days ago. So if you're worried about the notice, well, we normally give significantly more notice of our events than that. So thank you very much. Fiona Stanaway is a senior clinical epidemiologist at the University of Sydney. And in addition to Dr. Stanaway, I have one of my old political colleagues, Sandra Norrie, who has taken a very close interest in this issue. And she sees herself as a lay person, but a very informed lay person who's got some distinctive viewpoints about it. And she thinks she can, as well as the no expertise on the medical side, but she has a sense of the political as a consequence of long years of being a politician. So she's going to join in this discussion. Okay, well, I'll bring Dr. Stanaway in. Hang on, I'll give you the floor. I'd asked Dr. Stanaway if you could give us an outline of the situation with the virus in this country specifically, as you see it at the moment. So you now have the floor.
Sure, thank you very much.
Yeah.
Okay, so I guess just a couple of quick points about COVID-19 in Australia. So COVID-19 is a novel coronavirus that was first identified in early January in China and caused a massive outbreak. We had our first 4 cases in Australia on the 25th of January. And then that's increased over time to just under 6,600 cases as of this afternoon. We've had just under 70 deaths, most in older people. But yesterday we had our first death in someone in their early 40s. as I'm sure you're aware, Australia responded early with a ban on people coming from Wuhan and then China, followed by other countries that bans on travel from countries with other outbreaks such as Iran, South Korea, then Italy, and then now, of course, a worldwide travel ban, and then increasing social distancing measures from the end of March. And those measures have actually had quite a dramatic effect. I think possibly have been more successful and more rapidly successful than what was imagined. And we do seem to have really slowed the transmission of the virus in Australia quite substantially, which has put us in a very good position compared to a lot of other places around the world.
Okay. Well, hang on. Sorry, I'm just having this is the first time we've had 3 people on this. I wanted to get 2 just so I'm addressing you. The point you make about us seemingly being in a much better position than was anticipated is very interesting. And if you go back to, round about the part of March, I think you had various projections from Dr. Norman Swan, the ABC health reporter, that within a couple of weeks we could be up to about 80,000 cases, and obviously nothing like that has eventuated. And furthermore, if you look at inter-country comparisons, we seem to have had a remarkably low death toll, in particular, both in relation to other countries with substantial infections, including most European countries, but also as a ratio of to the number of confirmed cases. So, how can we account for that? Is it due to perhaps something to do with the pattern of urbanisation in this country, where we're more spaced out than countries where people tend to live in concentrated tower blocks and so forth? Or is it something to do with the way the thing's been managed, apart from the very early travel ban from China, which I suspect was significant? There's a piece in the Australian yesterday arguing that our testing strategies actually been very effective, not just in terms of the number of people tested, but in terms of the, I think what they call the strike rate, which is the proportion of actual COVID cases that have been identified. I wonder if you could give your take on that.
Yeah, so there's a few points that I think you've raised there. So I think the first one was really about the death rate in Australia and how we've had, I think of as of this afternoon today, when I looked at the update, 68 deaths, which is quite a low number considering that we have almost 7,000 cases. And there is quite a difference in death rates as the proportion of reported or known cases throughout the world. And there's important reasons for that. So some of the differences in death can be real, and that might be because you've got a different age structure in your population. So because people that are older are much more susceptible of dying from the virus, if you've got an older population, then your death rate is likely to be higher. It also depends on your health system. So if you have an underdeveloped health system, you have an underfunded health system where you don't have enough hospital beds, not enough staff, poor ICU facilities, not enough ventilators, then you might also have a higher death rate. But one of the the main reasons for that huge difference in death rate that we're seeing between countries is actually artifactual. So it's not a real difference in death rate. It's related really to two things: how they identify deaths, but mostly the testing that's done. So different countries are doing testing in different ways and doing different amounts of testing. And particularly in countries like, for example, Italy, that have a very severe outbreak, once their cases started to skyrocket, they were limiting testing to people that were being hospitalised with severe disease. So if you imagine you have a large number of people that have the virus, but you only test those that have severe disease, you don't test those with mild disease, you don't test people that are asymptomatic, then you're only identifying a proportion of the people with the virus. And so probably quite a high proportion of those with severe disease might die. So it looks like your death rate is really high, but in a way it's artificial because you haven't got the total quite correct, because you haven't identified everyone with the virus. And so that's an important difference in Australia, in that we have done quite a lot of testing. And so we are likely to have identified the majority of people that have the virus. We still probably haven't identified everyone, but we've identified most people, whereas in other countries, they've probably only identified a really small proportion of those who actually have the virus. So that kind of explains why you see those really big differences in death rates between countries.
There's another issue related to that. Dr. John Lee has written, a UK doctor, who's had a number of articles in the Spectator magazine, where he draws a distinction between dying from the virus and dying with the virus. So in other words, people who've got significant comorbidities might die, but those people might have died at almost the same time or in the near future anyway. And I think in the case of Italy, he referred to some information that suggested that only about 12%, in only about 12% of the death cases, which are counted as COVID deaths, is there a clear causality between the death occurring and the virus. So I wonder what you think about that point.
So I think it's not so much that the sorry, I've just got a very loud helicopter. I live just near the hospital, and it's a very loud helicopter going overhead. So there's a difference between so even in people that have a lot of comorbidities, the virus is still in a way responsible for their death. And it's just that they're at increased risk of that happening because of the other health problems that they have. But I think the point that some epidemiologists are making is that some of those people that are very elderly and that are very vulnerable, have a lot of other health conditions, may have died in the next 12 months. And it's almost like those deaths that would have happened at some point in the year are being brought forward and concentrated over a very short period of time. We don't know whether that's true or not. It's likely that at least some of the deaths are like that, so that they're in people that probably would have had quite a low life expectancy, but not all of the deaths are thought to be in people that would have died in a short time frame. And I guess we won't really know that until we're out of the epidemic and we can see what mortality is like afterwards. I think the other point to make about that is that in a way that concentrating the deaths that might happen over a year in a period of about a month is actually why controlling this virus is important. Because if you imagine you have a year's worth of really ill health that's going to result in death over a month period, you can imagine that the huge impact that has on the hospital system. Whereas if those deaths are spread out like they normally are over a longer period, it's much easier for the health system to deal with that volume of very sick people.
Okay, thank you. Now, Sandra, you there?
Yes, I am. Can you?
I'll now put you in centre stage to I think you have a different view about the competence of the government's handling of this issue in the early stages. So away you go.
Okay, look, thank you. Look, much of what I'm going to say, I admit, is really for when this is all over and we look at how government handled it, right? There's no point crying over spilt milk. And what I'm about to say is also the product of discussions I've had with former colleagues and how we feel we might have handled it. Now, maybe that's just a bunch of old pollies getting up themselves, I don't know. But it goes like this. I'm watching all the news in January and I'm seeing what China's doing, and that's a country that I don't believe has to worry about if a lot of people die, because that's the nature of their regime. But they're taking it very seriously for whatever reason. Maybe they're embarrassed because after SARS, here we go again. I don't know. But they're taking it very seriously, and I'm not seeing that urgency within Australia. And I'll give you an example. About January 21, 22, I'm about to buy a ticket. And I ring my travel insurer, who always does it for me, and he said, just be careful. They haven't declared a pandemic, but it's so obvious where this is going. Your travel insurance will be voided. So I didn't buy the ticket. So I'm already aware. About 20 January, I'm getting very nervous, so I don't book my ticket and so on. I have family in northern Italy, so I suppose that makes me extra vigilant. But I start to see what's happening in a part of the world that I really care about as well. And then I think, what would I want to do if we're going to face a pandemic? We don't really know if it's coming, but it looks like it might. We're in that terrible grey area, but there's enough evidence, clearly not for Donald Trump, but there's enough evidence there for a rational person to go, this could go belly up. So what do you do? And why should you do what I'm about to say? I would have thought talking to the government's ad agency and developing a competent, gentle hand washing and cough protocol advertising campaign. Have that ready or even start it. Why? Because there's no nice way of telling the public there's a pandemic coming, but you're going to need their help and you're going to need to educate them and you're going to need to make them aware. So that's one of the things I would have done. The other thing I would have done is I would have called up something that I actually used to manage. And it used to be called the Industrial Supply Office, and it's now called Industry Capability Network. Well, they're a bunch of old blokes, tradies and so on, who sit somewhere and they know where every widget with pike and twist or without pike and maybe a twist is manufactured in Australia, and particularly in New South Wales, somewhere out the back of Smithfield or the back of Fairfield. So much so, just so you know, we were able to manufacture a lot of stuff, including the stadium, purely from inputs within Australia and New South Wales for the Olympics and for our Mine Hunter, which is a very sophisticated naval vessel. Why wouldn't we be talking to them and finding out late January, early February, who could make some sanitizer, who could make some masks, who could do this, who could do that? They knew then we didn't have enough masks. I can understand that they didn't want to announce it, but anyone who knew anything knew the shipment was coming in April. And indeed, the masks have arrived about 2 weeks ago, because the rations have been pretty tight in hospitals. And I think the public would be horrified if they knew just how tight it was. That tells me, number one, maybe previous Labor government as well, I don't know, but this has been a government for a while. The pandemic plan that's supposed to be there had not been adhered to, because you would not let yourself be where you have to wait till April for masks, right? So they start telling us you don't need to wear masks in public. Well, I understand that masks aren't foolproof. I understand that mostly they stop a person with the disease not spreading the droplets to others. But I find it hard to believe that masks don't have a role, no matter how minimal, in reducing the spread. So my guess is that along with the Donald and Boris, I think Australia was going to go down the herd immunity until they worked it out. And don't forget, we now look safe, but up until March, I think 24, 25, our growth was exponential. Small numbers, but it was exponential. You were entitled to fear the worst. I believe the fact that we don't have porous borders, we're not so heavily a smoking country and age. And I do think that our, Pet and I had this discussion, I do believe that our urban planning gives us a form of social distancing anyway, because we live in bungalows and we're not in the...
Yeah. And,
Okay.
it's easier for us, I think, to
Sandra, why
stay
don't we
apart from each
let
other.
Fiona respond to that?
I just want to say this is, okay, we've dodged the bullet. That's fantastic. The reason I'm uncomfortable is because we had a government that either didn't see it, didn't want to see it, or really fundamentally believes in herd immunity. I'm concerned about when the lockdown gets lifted. There are people at the Grattan Institute that I really respect, like Stephen Duckett, who argue we should keep the lockdown for as long as possible. Yes, there is an intersection, a sweet spot between the economy and health, and we do have to find it. But if we get it right, if we take a little bit more pain now, the chances are we can really get rid of it, because we're an island, because of this, because of that. And that means then you have to control it coming in with quite strict quarantine for international travel. It's not a pretty picture, but I'd rather unless someone, I mean, I'm prepared to be contradicted and have my mind changed, but I'm concerned that this government will go down the economic path more rapidly than it ought, because that's their history. It's part of, to me, it seems to be an ideological thing. It's in there. They could have done such simple things that I've described at the beginning and didn't. That doesn't hearten me. And then I saw, Prue Goward's stalking horse talking about the baby boomers having to cop one for the country while we open up the economy. I can see it starting to happen. So that's my concern. My criticisms before don't matter now, but in the analysis afterwards, I think we should look at where this government is going.
Okay, thanks, Sandra. Fiona, lot to respond to there.
Yeah, so I mean, I think you're right. I think the early response could have been a lot better, and that we've been lucky in that our later response has ended up being very effective, and we've got ourselves back into a good position. But there were those couple of weeks there in March that it was very frightening, watching the rate of increase. I think a lot of the points you raise actually are interesting, because they're exactly what Taiwan did. So Taiwan is a country where I used to live, actually, and Taiwan experienced SARS, like a couple of other countries in Asia, and really learnt from that experience. And they had like a centralised government team, I think, that were responsible for pandemic planning and control, that were established as a result of SARS. And one of the first things that they did was to ramp up mask production. Taiwan actually produces a lot of masks already, but they made sure that that government team took over that production and drastically increased their production so that there would be enough. So I think you're right. The earlier response could have been better, and would have, perhaps prevented those numbers getting as high as what they did. Because if you look at Taiwan's numbers, they're extremely low and have been low really throughout. I'm just trying to think of some of the other points.
Taiwan, sorry, go on. I was going to say, didn't Taiwan derive some benefit from the fact that the mainland regime actually imposed some travel restrictions from the mainland to Taiwan as part of in order to punish them for something or other? But they
had their own travel restrictions, and they also used a lot of technology. So when people were coming in through the airport, they had these QR codes that people would use with their phones, and then they would go in and sort of fill out a survey about where they'd been and for how long, etc. And they were put into a risk group based on that, and then either went straight through the airport, or they had to have extra screening done. And they had a similar approach to isolation. I think that Singapore was using that, again, was technology based, where they were trying to make sure that people were actually complying with the quarantine after returning from overseas. And they have a lot of data linkage, where they were able to link people's travel history with their medical records, so that they could when people were going and using health services, they would have that linked to whether that person had been a recent traveller, all that sort of stuff. So they had a very rapid response because they were prepared, and that's because they experienced SARS and they had quite some bad outcomes with SARS, and so I guess in a way they learnt their lesson.
Okay, can we change the topic a little bit now? I'm just interested in the various initiatives to develop vaccines, which, by common consent seem to be a long way off, although I thought I caught a story on the news this morning about a team at Oxford that were in human tests with a vaccine that they thought might be available in September. I would need to check that. That seemed far earlier than...
I mean, possibly, but they normally take quite a while to be tested, to make sure that they're safe and to make sure that they're effective.
But far more imminent seem to be some therapeutic treatments based on antivirals, blood plasma from people who've got the antibodies for it, and so on. The treatments for Ebola, which seem to have some applicability to COVID. I just wonder what your view is about the kind of moral dilemma that arises when you're thinking about trying out a drug which may not have gone through the entirety of a randomized controlled trial of the kind that would normally be required before a drug was introduced into widespread use, but which seems on the face of it to have some significant benefits in a context where people are dying all over the place. There seems to be a real moral tension between getting it out there to save some lives and holding back until you're certain that the thing is both safe and efficacious. You got any thoughts about that? I mean, it comes up in the context of the hydroxychloroquine.
Hydroxychloroquine, yeah.
But not only that.
So I guess the things to say about these drugs is so yes, they do have potential, and that if we can find effective treatments, that'll make a big difference, because, as we talked about at the beginning, that the big issue with this virus is the burden on the health system. And so if you have treatments that can mean that people aren't as sick, it means the health system could probably handle a larger number of cases than it can at the present time. So having effective treatments would really help handle the epidemic, and is quite likely to come sooner than a vaccine, because many of these drugs are already around. But we do need to know that they work and that they're safe. So, and this is something actually that there's a clinical epidemiologist where I'm always looking at the evidence that's behind both the treatments and the tests that we use in clinical practice. We always want to make sure that when we're giving treatments or interventions to patients, that they actually are of benefit. And that's not always clear, because when someone's very unwell, and you give them a treatment and they get better, it could be that treatment has helped them to get better, but it could also be that they were going to get better anyway, and you don't know that. And the problem with using that sort of, I guess, very weak evidence to say, oh, this is great, we should use these treatments on people that are very unwell, is you actually don't know whether those treatments can be quite harmful and may actually cause deaths that may not have happened anyway. So at the moment, there's a lot of very large trials going on around the world. And so there is access to these drugs, but they are only through trials. And there's already been cases of people getting access to particularly the hydroxychloroquine, which is an anti-malarial drug, and also used for some immune diseases, that people have got access to those drugs and have taken them and have made themselves very unwell. So I think that reinforces that, it's great if we can have a treatment, but we need to know that it works. Otherwise, we may be harming people more than we're helping them.
Right.
Can
Okay.
I ask a question on that point, Fiona? Two things. I think Peter was getting at, or maybe he's not, but the French doctor who did the first very small trial on hydroxy, whatever, I call it Plaquenil,
Yeah.
said that morally he doesn't want to do the double blind. He says kind of any port in this kind of storm, because how do you morally withhold the treatment from someone just to do your double blind?
Yeah, so that's a common question that my students ask me when I'm talking about randomized controlled trials and why we need to do them. And yes, so when you're doing it, so you don't do a randomized controlled trial for everything. So for example, there's never been a randomized controlled trial that shows that it's better to have a parachute when you jump out of an aeroplane than not. So there are absolutely situations where it's very clear that something is of benefit, and it would be immoral or unethical not to offer that. But the problem is, it's most drugs. It's not like that at all, and people, I think, in the community tend to have an overestimation of how beneficial drugs are. And so when you're doing a trial, for example, you might find that many people will get better regardless of what you do. Many people, well, probably not many people, but a small proportion of people will get worse regardless of what you do. And there's only that small number of people that actually change because of your treatment. And so there usually aren't these very, very huge effects that would then say, look, it's immoral to do a trial. Often the effects are small, and the differences between groups that have the drug and that don't have the drug are very small, and that's exactly why we need to study it. So yes, if there was a very, very clear benefit, and when that does happen in a trial, they actually stop the trial, because when they can see that something is clearly, if everyone who gets the drug dramatically gets better and the people that don't get the drug die, then that's a very clear difference, and they would stop the trial. But that's not what most trials show. The difference between the groups is often very small, and so that's why they are justified ethically. You have something that's called equipoise, which means that you think it might help, but you're not sure. And so and that's how the ethics works, you see, because you might be withholding something that's beneficial, but equally you could be giving something that's harmful. And it's because you have that equipoise between those two that you can say it's ethical to give the trial.
Okay, well, we've got a full chat stream, so we better start addressing some of those. Well, a lot of them are just comments. So I'm trying to find questions. Here we are. Fiona, did the Australian authorities rely too much on the past experience of SARS and MERS not progressing to our continent in assessing and managing the risk of coronavirus spreading this year? I wonder that myself. I mean, in the early stages of the epidemic, I think psychologically, many of us, and I put myself in this class, just thought, oh, it's another one of those SARS MERS things. It's not that great a concern. But
yeah, I mean, I think possibly, and it's probably related to, though. I mean, they're all of those three. So MERS, SARS, and COVID-19 are all coronaviruses, and so I guess, you know, it would have been reasonable to think that they would behave in quite a similar way, but in fact they're quite different in that MERS and SARS are much more lethal. But also less infectious, and it's that sort of combination of COVID-19 being more infectious and actually less dangerous that enables it to spread. And so perhaps, yeah, people were a bit complacent and didn't and didn't realise it was going to be what it is. I mean, I don't think anyone in early January would have imagined the scenes in New York and Lombardy. You know.
Right.
Yeah.
David Horrocks, hindsight is a 2020 vision. So political, what would we have done? I think it should say it has no place in a serious situation such as a pandemic. Well,
I think
we learn from experience, don't we?
Yes.
That's important. Yep. Sorry,
Yeah,
did you want to comment?
and I think probably for years to come there will be a lot of health policy analysis about how different countries have responded to this pandemic, and that hopefully can be learnt from, so that next time we all do a better job.
Okay, philosophy and critical thinking. I think that's the precautionary principle. Well, I think that's a comment, isn't it?
Yeah.
Unless you want to elaborate somewhere. Okay. Mulan asks, will COVID-19 radically reduce infectious disease now that the society has learned the hard way?
So I think definitely, and there's always some evidence. There's already some evidence for this, that the rates of influenza infection are lower than usual, and that's because we're social, as well as hand hygiene, we're social distancing, and so there's much less spread of viral and particularly respiratory viral infections in the community. Before this virus, it's interesting, I work in the School of Public Health in the University of Sydney, and very few of us are infectious disease epidemiologists, and I'm not an infectious disease epidemiologist. I'm an epidemiologist, but I deal much more in chronic diseases, and it's because in countries like Australia, we generally think that chronic diseases are the more important diseases for our country to manage. So there's already been an enormous fall in infectious diseases in most developed countries, but they're still there, and they still can cause quite serious disease, I guess, as we've seen. I'm not sure that the decrease that we're seeing at the moment in influenza because of the social distancing will be maintained. Hopefully some of the messages around hand washing can be. I think everyone's learnt to definitely wash their hands much more thoroughly than perhaps they would have. And that obviously has a lot of benefit, not just for COVID-19, but also for influenza and cold and flu viruses in general, and also for gastrointestinal viruses. So, having good hand washing technique does help our society reduce those particular sorts of infectious diseases. Okay.
Can Fiona please speak to the various models and strategies and tensions in the various exit options? Now, other people are going for an hour at least.
Sure. Goodness. And I think this was a little bit what Sandra was referring to as well, about different sort of exit options. So these are hard, because I think one thing that's really important to understand is that models are just that. They're not real. They're based on assumptions, and those assumptions are really a best guess, but we don't know that they're 100% correct. And the models will change over time as we get more information about the virus, we get more information about the epidemic, we see how countries respond, we see what changes they make, and how the epidemic responds to that. So I think that's the first thing to understand about the different models. In terms of exit strategies, I think it's still unclear what the best exit strategy is. Australia, in some ways, is in a very lucky position because we're at an earlier stage of the epidemic, so we can watch and see what people are doing overseas and see what works. There's been a lot of discussion, I think, the past couple of days about New Zealand's elimination strategy, and I know, Sandra, that you're interested in this, and the idea of that is, rather than the approach that Australia has at the moment is what's called a suppression strategy, where you try to get the virus to low numbers so that it doesn't, the number of severely ill people don't overwhelm your health system, but the virus is still there, spreading throughout the community. And that's been chosen as a strategy because it was considered to be a realistic strategy. The strategy that New Zealand is adopting is elimination, which means that the aim is to completely get rid of the virus from the community. And whether or not that's possible is being based on modelling. And so I guess the thing to keep always in the back of your mind is that the modelling is based on assumptions, and so we still don't know whether or not that's possible. If you look at, say, South Korea, for example, they're having this very, very long tail to their epidemic. So they managed to stop their rapid increase that was happening in early March, I think. But then they've had this long tail for a month where they've still had quite low levels of infections, but still getting new cases all the time. So it's hard to know what will happen in Australia in the next, few weeks, months, whether we'll be able to, through these social distancing measures, reduce the cases to almost nothing, or whether there'll still be some cases floating around. And the difficulty with that is if you still have even just a small number of cases there in the community, once you remove those restrictions, those cases can flare up again. And so I'd say that, the approach and the exit strategies will likely change over time as we observe what's happening overseas. And then also as we observe what happens in Australia when we remove some measures and see whether things can be maintained. That there's no really easy answer in how to manage the next few months.
Right. Just on that, I'll just put something on the screen. There's in the US in the last, just recently, there have been a number of articles that make the case for universal testing on the theory that if you could test everybody, you could make sure that those people who are carrying the virus and therefore potentially infecting others could be quarantined, and if that were done systematically and comprehensively, that the virus would just die out. I mean, it would be a huge task, although interestingly, if you go back to the 1950s, we had a universal testing regime in this country for tuberculosis, which was, those of us in the older age brackets will remember the X-ray caravans trundling around the streets of Sydney. They literally made it mandatory for everybody over the age of 14 to have a chest X-ray. And basically, if you were going to eliminate it entirely, you'd have to pick up all these asymptomatic people, presumably. So, Fiona, do you want to just comment on that briefly?
Yeah, so testing everyone, isolating everyone who's positive is absolutely a way to control a viral outbreak. I guess it's just a matter of whether or not that's going to be logistically possible. So that has been done. So there was a town in northern Italy that had the first death, and they tested everyone in the village. That was about 3,000 people. They had 88 people that were positive. They put them all in isolation. They tested everyone again. They had about 8 that were positive, and they completely eradicated the virus. Whether or not it's possible to do that in a country of 25 million may not be the case, and it may be that you test people that are at high risk and then perhaps do some random testing of others to see, whether there seems to be a high rate of transmission in the community. There's even this idea, I think it was yesterday on the news from the CSIRO, about looking for virus in sewerage, because it often, in people that are infected with coronavirus, they do actually have small amounts of viral antigen in their urine and feces. So it's just as a way of trying to get a hold on how much virus is circulating in the community and whether it's increasing. The other problem with testing is, well, firstly, availability of testing and whether we would have enough to do that. And the second is the accuracy of the testing. And so usually any test well, what I should probably say is no test is 100% perfect. So when you do a test, there's what we call false negatives, where someone actually has something, but the test result says they're negative, and a false positive where they don't have something, but yet the test says that they do. And particularly when you're testing, when you've got a very low prevalence of a condition in the population, and you're testing large numbers of people that actually don't have the virus, when you get a positive result, it's probably more likely to be a false positive than it is to be a true positive. So depending on how good your test is, there can be other problems around trying to test a really large population where you actually don't have a lot of the virus. So whether or not that's a good strategy, I think, depends on a lot of factors around testing availability, the test accuracy, and also how common the virus is in the population. And the other thing to remember is that it's really a movable feast in a lot of ways, that, you know, you might do the test and it's negative and you really are negative, but the next day, you know, you get exposed to the virus and you get infected. And so it wouldn't be that you would just test everyone once. You'd have to have rounds of testing, and in a large country that may not be feasible.
Okay. Some people have comments. I'm just trying to sort out the questions from. Here we are. This is a very, for both of our, hang on. Philosophy and critical thinking. There's somebody whose name is Philosophy and Critical Thinking. That's a good name. For both of the guests, what are your thoughts on moving on to a short-term full lockdown with a UBI, whatever that is? Would this help shorten the overall length of social distancing restrictions?
Yeah, so that's really the elimination strategy, which is to try and completely get rid of the virus. And I guess that the thing to say is it's not clear if that's possible.
Okay.
Yeah.
Next, David Horrocks. When this horror has finally passed, what can governments do to prepare us for the next attack? Oh, that's a very pertinent question, because what we're experiencing now may well be far from the worst case scenario. If you combine this level of infectiousness with much greater lethality, it could be very nasty indeed. This could be a blessing in disguise. Sorry, I shouldn't answer. You're the
well, no, you feel free. I mean, if I'm happy for it to be a discussion. It's it doesn't have to be all me.
Right.
Peter, if I could, I think what they do have to do is, I think we do have a pandemic plan. I think it's been sitting on the shelf for too long. And the example I gave earlier of the mask, we should never, ever get to that point. And we should already know in advance who can pivot their production line, either for nothing or a bit of money, so that they could step in and provide the elements of what we might need in a pandemic. That should be a lot more, a much more alive option. And I think the previous question, or 2 questions ago, asked what we thought about UBI. I don't know what UBI is. My main
it's come up, universal basic income.
Oh, I see. I just look, my main concern, I don't know, clearly I don't know the answer, but I do know this. I don't want the government to go down an ideological path, even if it's just a little bit of their thinking. I want them to rely very much on the medical evidence and advice and recognise this one basic thing. And it's not just me saying it, it's Bill Botel's, it's Stephen Duckett, who I admire greatly at the Grattan Institute and so on. And it's that if you get the health policy right, you're doing the economy a bloody great big favour in the long run. If you try to get the economy right without dealing with the health issue, you will plunge back into chaos sooner or later. People can't spend. businesses can't invest if they don't have certainty. So that's my philosophical position. I just don't want this government lifting the lockdown that we have too quickly for sort of ideological reasons. They may not realise they're being ideological, but it is a pattern that I'm seeing.
I think, as well as the coordinated government response, which is important. There's lots of other lessons to be learnt from this response and from the different situations we're seeing around the world, and some of those are related to how to control a pandemic, but a lot of the other things are around equality in our society and safety nets. So having a well-resourced health system actually puts you in a good place. So part of the problem with our being able to respond to the pandemic is that many countries have health systems that are stretched, and there's no redundancy, there's no extra beds, there's no extra staff. And so that makes it, and in many places, not everyone has access to the health system, so those kind of issues of social equality, I think, have really been shown as important in how you can effectively manage the pandemic. And even, a country like Singapore that has been lauded for what a great response that they've had and how well they've managed it, now is falling off track because they have this large population of temporary workers who are on very low income, have very few rights, and are living in very cramped, poor quality accommodation where the virus is spreading rapidly. So I think, as well as, the pandemic response strategies that we have in place, this pandemic is really an opportunity to think a little bit about how we structure our societies and how we think about equality, because it's shown that those societies where there's a lot of inequality can actually have a lot of vulnerability in these sorts of situations.
Okay. Listra Hare. Lisa sorry, I won't try to pronounce that. Apologise if this has been covered already. If it hasn't, can you address the question of whether people who have had the disease getting the antibody for it? Wouldn't this only be in some cases?
So I think that means the immune response that you have to having an infection. So there has been some research in Australia by the Doherty Institute looking at people's development of an antibody response to the infection. And it does seem to be that people do develop an antibody response. And so the idea of an antibody test is a little bit different to the tests that they use to diagnose infection at the moment. And that's really not when someone has just caught the infection, but probably a little bit afterwards, they'll start to develop this antibody response, and then they should be positive on that test. It's not clear because it's a new virus how long that immunity will last, but it does seem that most people do develop some kind of an immune response to the coronavirus.
All right. Andrew Westcombe, question for Dr. Stanaway. I'm having trouble seeing a good justification for the herd immunity strategy that we're seeing in UK and Sweden. Is this overly simplistic? Well, that's very interesting because Sweden's a bit of an outrider, isn't it, in terms of the broad strategy they've adopted?
Yeah, so it is. And I think the other thing to say is that, so the herd immunity strategy, where you basically just let the virus rip through the community, you have this massive amount of death, but it's all over in a quick period of time, and then that's it, everyone's immune, was kind of touted as an idea in several countries, including the UK. But then most of those countries did a quick backtrack once they started seeing what happens when the outbreak gets out of control. So I don't think there actually is a country now that is, though I could be wrong, that is using the herd immunity approach. So and there was actually a Swedish minister talking on the TV this morning about the criticism that Sweden is getting. And so Sweden doesn't have as strong a response as some of the other European countries, but they still do, and so people can still go to bars and restaurants. They're still open. They can go to the gym. There is some limitation, as I understand it, on public gatherings, so it's not a completely let it rip scenario. But interestingly, people are still behaving differently in Sweden. So they're not going out, they're not traveling because they're frightened. And I think, and I know, Sandra, you're concerned about this response of just trying to protect the economy. And I think, I don't think that it's all economic arguments, but some of the voices that seem to kind of almost have this idea that if you didn't have a lockdown, we'd have the economy that we had 6 months ago. It's unrealistic, and particularly when you look at a place like Sweden that did try to keep things open, and there's businesses that are failing anyway because people are frightened and they're not wanting to go out. So I don't think that there are any countries now that are taking the herd immunity approach, and the main reason for that, I think probably the stimulus for people to change their mind was a modelling paper that came out of the University College London, and it's really all around this idea of overloading the health system, and that if you allow the virus to infect a lot of people and you have this sudden large number of people that need hospitalisation, that need intensive care beds, and that need ventilators, your health system collapses. And then that in turn has wider implications. So, you could be at home having a heart attack or stroke and the ambulance won't arrive because there's no ambulances left. You may not get your bed in hospital because there's no hospital beds, or, you may have your doctor or nurse make an inappropriate decision because they're so tired, because they've been working double shifts because a third of the workforce is unwell and at home. So I think once the modelling started showing that the health system couldn't cope with such a huge number of cases in a short period, countries stepped away from a complete herd immunity approach. They may have done a more soft approach in terms of social distancing. And in fact, if I can just share my screen, I can show you a good example of that, and using Sweden. Here we are. Yeah, so this is, can people see that?
No. Yeah, I have to.
Here we are. Excellent. Yeah. So this is a great website, Our World in Data, and they've got these graphs that sort of track the number of confirmed deaths in different countries over time. And I've just highlighted here Sweden and Norway because they're neighbouring countries that have really similar populations but have had very different responses. So Norway has had a very strict shutdown, and Sweden, as I mentioned, has not. And here you can see the difference. So I think as of today, Sweden probably has twice the number of cases as Norway. But remember, the number of cases is not always representative of how many cases you really have. It's how much testing you're doing. But it has almost 10 times the rate of deaths. So Norway, I think, has about 160 deaths, and Sweden has about 1,400. So I think the difference between those two countries, I'll just stop sharing that now, is a really good example of how social distancing, it really works.
Okay. You just get that back. All right, Fiona, this is shocking. I've been accused of political censorship. Don't appreciate bypassing my question to Sandra, which looks like a bit like censorship of what is a politically loaded question, in my view, fair points about the economic decision and crowing over it. Now, we must not engage in political censorship, so I'll scroll back and find the question.
Which question was that?
I already answered. Peter,
Actually, no, he had a two-part question. Here's part one. What does Sandra, this is for you, Sandra, you've got a fan. What does Sandra think about grandstanding and thought bubbles in concert with inconsistency of, and then the second part, approach such as with economic support to sports figures, allowance of horse trade racing and organisations, plus exclusion of casuals and temporary visa holders being told to pack their bags. Now, as a former Minister for Sport,
amongst other things,
you'll no doubt have a
Look, I agree with what you're saying, and it's not as significant as what I was saying before about what I felt was an ideological approach or even a complacent approach initially. But it does speak to, I think, being vulnerable to pressure from industries and so on. I do think, look, this is, you won't believe this, but it's actually not a Labor woman's response. But I don't trust the way the federal government has handled it, so I don't trust necessarily what they're going to do in the future. I don't understand why we could all go to sport on Saturday, but suddenly by Monday we were going to shut down the large sporting events because of social distancing. It was just all so inconsistent, and I think there's a bit too much politics here. There's something I haven't said. For example, we now boast about.
You're saying there's too little politics.
Look, we boast about the level of testing that we do now. I don't think many Australians know that increased rate of testing is only about 3 to 4 weeks old. There were people being admitted to hospital for whatever reason in March, maybe late February, with flu-like symptoms, and if they hadn't been overseas, they weren't being tested. So our testing regime was really a bit up the putty, in my opinion. We are testing a lot now, I agree with that. But harking back to Stephen Duckett, the Grattan Institute, and others who believe that we should have a crack at the elimination approach, is that we have to do massive testing. And their argument is also this, that if you go hard and go for the elimination strategy and you don't make it, you can come back to what they call the Goldilocks strategy, whereby you really try to find that sweet spot between very few cases and as much of the economy open as possible. And I'm just hoping that the government's learnt its lesson. And by the way, I'd attack Queensland. They held a local government election when our figures were
I know.
exponential. Right?
I'm a Queenslander actually, Sandra,
yeah.
and I told my mother, who is 81, not to vote because I didn't want her going outside. Yeah, but it was because there was a by-election involved. So that's it. Yeah, it wasn't the local council elections that they were concerned about. It was the by-election. But yeah, I completely agree.
No, I get it. But governments of all persuasions have played their little bit. And I just think this is too important. The reason I say this is if I could figure out by about the end of January, early February, this has got legs and we should be starting to do a bit of this and a bit of that doesn't cost too much. Like I keep referring to the coughing and hand washing protocol. Then if I can figure it out, then government should have worked it out. So that's why I'm cranky. And to the person who made the comment that, I think someone was maybe having a crack at me, I agree. We've dodged the bullet. Arguing about what should have done is not important for the minute, but it does behove us to recognise that government hasn't always been on top of this. They have an ideological bent. Let's keep on top of it. But you're right. The analysis of what they did wrong at the beginning is for the analysis when we're out of this terrible problem.
Okay, I've got some bad news for you, Sandra.
What's that?
Philip Lambert hasn't heard your rant. So, sorry,
well, that's okay.
over and out.
Is that my friend, Philip Lambert? I know Philip. I think I know who he is. I'll talk to him.
All
right.
Bring him up and give him a serve.
Yeah. I'm just trying to...
Moving on. Reflections, somebody named Reflections, asks, ethics versus evidence of COVID response. How cost of current response tally with cost to societies? Lockdown response difficult to justify if quality and dub, whatever that is, used to measure cost
So
benefit.
that's quality, quality of life years, and
right, okay,
yeah.
yeah.
Oh,
That's,
shooters.
somebody, sorry, you're right.
Oh, sorry, I've just lost my screen.
Hang on.
Can you?
No.
Sorry.
You're right. I'll put you back in charge. Yeah.
Do you want me to answer that one?
Well, I think the point is, yeah. Well, you know the point, but yeah.
So it's really hard to kind of weigh up the economic impact versus the lives saved or the lives lost, because we don't actually know what would have happened if we did nothing. So we kind of don't know how many lives are being saved. I mean, it looks great at the moment. We've had hardly any deaths. And so then it's easy for people to think, oh, we've caused all this damage. There's all this loss to the economy, and there's no deaths. So what we're worrying about. But if we didn't do anything, then there could have been lots of deaths. And I guess we're never really going to know what those deaths would have been. I mean, the modelling kind of can give us a guesstimate, but as I said, that's based on assumptions. So to do an economic analysis where we think about, oh, we've lost this much in the economy, or these many people have lost their jobs, compared to how many lives have saved, is really hard.
Right. This is more a comment than a question. I absolutely agree with Stanaway about wearing the mask the other day. My nephew, who lives in Norway, was driving his car not wearing a mask. He got stopped and fined by the police. Okay, we'll take that as a comment. Andrews Hex, for preparation against pandemic, see YouTube, Bill Gates' excellent TED Talk several years ago. Yes, I've seen that video. It's actually remarkably prescient, actually. Anyway, that's another comment.
There's quite a few, or I think I think Andres is asking about schools, teachers in schools. Should we talk about that?
Yeah, sure.
Yeah, schools is really complicated, and I think that's borne out by I guess the difference in advice between the states and federally. And I think actually Norman Swan put it really well yesterday in talking about this, in that it's not that there's, in anything, it's not that there is no risk for things. It's not that there's no risk when you go to the shops and buy groceries. It's not that there's no risk when you catch public transport if you need to go to work. Those activities do have risk. But if you're careful, the risk is low, and you need to weigh up those risks against benefits. And that's really with anything that we do. And I guess that's the approach that's been used with schools, which I agree is very hard for people to understand when children are told that they're, not allowed to go to the park and play on equipment, but yet it's okay for them to go to school. And really those decisions are based on that. If you look at the countries that have had large epidemics overseas, particularly Wuhan in China and North Italy, the number of cases in children is very low, and children don't seem to have severe disease, with a couple of exceptions, but generally that's what happens. And that it also seems that children don't seem to be responsible for a large part of transmission. It's usually children are getting it from other people in their household rather than spreading it. And so for those reasons, in the modelling that's been done to date, and again, taking that proviso that the modelling is based on assumptions, but most of the modelling shows that, yep, shutting schools would probably reduce the infection a little bit, but it's not a big effect. And so when you're looking at something that doesn't seem to have a big effect, then perhaps the harms of doing that is going to outweigh the benefit. And those harms, are people missing out on education, and parents of those children perhaps not being able to work. That said, I think in some ways, the way I think about it is quite similar to the advice about working from home, which has been, if you can work from home, it's good because it's reducing your risk. And it's also reducing the risk of other people that can't work from home and have to, perhaps catch public transport or be in the workplace. And then there's fewer people for them to be around. So it's also decreasing their risk. And the same is kind of really for schools. So the approach really to date, though I think it may change now that the case numbers are dropping, and they're thinking perhaps of letting school kids go back and perhaps on a roster system, is that, if people can keep their kids at home and there doesn't seem to be a lot of harm from that, then that's great. But it's important to still keep the schools open for the children that don't have another option, whether that's because the parents need to work, their home environment is less safe, they don't have access to good internet or a computer. And so, yes, there is risk. There is a small risk to teachers, just as there is a risk to anyone every time you go outside and you interact with other people. But it's considered that risk is small and that the benefits are outweighing those risks. And again, if there's fewer children at the school, as well as the risk being less to those children, the risk is also less to the teachers. I hope that kind of answers that question. It's a very hard question to answer. So it's not so. So I think so. That's the question that you've put up there. That's the one that.
That's right. Yeah.
So I hope, Andrews, that's helped.
Why are they safe to work while others are not? Children.
Yeah. So it's not about people being more or less safe. It's about that benefit to harm trade-off that, healthcare workers, it's not really safe for them to go to work. It's probably, that's the most dangerous profession at the moment if you're going to be exposed. But the benefit of those people going to work is really important. And so that's how the decision is being made. It's not that there's no risk. It's that that risk is considered to be acceptable given the benefits.
Okay, next, Tony Morrow. Thank you, Fiona. Is it true that China outside Wuhan has been minimally affected, in particular Beijing and Shanghai? And if so, any explanation? Can't all be social physical distancing? And just following on from that, how credible do you think the figures are?
Yeah,
there's somebody, some research institutes.
Hard to say whether they're credible, and I do note that I think it was yesterday they added about 12 or 1,400 deaths to the figures of the earlier outbreak. So some of the control does seem to the control of rates in other parts of China. So they locked down Wuhan as a city to try and prevent the spread, and they did actually have social distancing in other cities. So they had sort of partial lockdowns in Beijing and other cities, as far as I'm aware, that have now been gradually lifted. Whether we can trust all of the numbers coming out of China is hard to say, and I can't really answer that. It does seem to me, I know that they were having a lot of people returning from overseas, and it did seem to me that their numbers of new cases were very low considering the number of people that were returning home. But yeah, who knows?
This is Barking Madeline. It's a great name. So not wearing a mask in his car. Maybe he was going to put it on when he reached destination. Many reports of police overreach in various countries. I think there's a general point here that a lot of the resistance to these measures is when they seem to go overboard. You probably read about the demonstrations in the state of Michigan where the governors sort of prohibited people from buying seeds to to plant vegetables and so forth. I think governments have to be very careful to not be seemingly engage in unnecessarily draconian and trivial, like the arresting of that, the initial finding of that woman and giving her daughter a driving lesson down in Melbourne.
Yeah. Yeah, and I think the other important thing is that some of it is that going back to normal afterwards and, removing these extra powers that people have been given and these extra restrictions. Yeah.
Reflections. I'm on the side of an ethical response here, just interested in how evidence is being used and implications for future reliance on evidence, good, bad and indifferent, to justify government actions. I'm not quite sure what the point is there, but we're all in favour of evidence, I presume, being
Peter,
used.
if I could just jump in there, you won't know till the end, and then I think at the end there'll be some kind of analysis or questions from the opposition or something, FOIs, what have you. It's only then that we will be able to estimate and see what advice was government given and what did they do with that advice. We'll only be able to piece that up afterwards, I think. But
Right.
Of course, the question is right. I mean, it has to be done ethically. I mean,
I think too this is hard because it's actually a situation where we don't really have a lot of evidence. I mean, modelling isn't evidence. Modelling is kind of a best guess based on the small amount of evidence we have, and then some assumptions about what's going to happen, and then that produces a model. So that's not actual evidence, and the problem is we don't have any evidence, and that's why the decision making is really hard, and why sometimes things don't always make sense, and why sometimes things change, because we actually don't really know. It's a completely new virus, and so there isn't really a lot of evidence for us to go on.
And this thinking, Peter, is there a concern come next virus pandemic outbreak Australia might overreact? The response to that, it must be you could overreact or underreact. How do you differentiate whether an emerging virus somewhere in the world is a mortal threat or one of the SARS, MERS, bird flu things that we've seen and really haven't impacted us that much? Is there a good way early in the piece to make that distinction?
Yeah, sometimes it's complicated. I think in terms of trying to find these pandemics early, it's quite important. So these viruses usually come from animals. They're what's called a zoonosis. So they jump species, and that's why they're usually so severe. So there has been a recommendation that we perhaps keep a better eye on particularly coronaviruses that are circulating in animal populations, and we try and do things about trade in wild animals that perhaps exposes people more to animals that do have these viruses circulating. It's hard to know whether, I would hope that in fact based on this we would have a better reaction. I mean, when you look at the countries that responded well to this particular pandemic early on, the ones that did a good job were the ones that had experienced SARS. So places like Hong Kong, Taiwan, Singapore. So in those situations, they actually could have a very good early response that meant that they didn't have to go through, to some extent, the big shutdown that other countries have had to have. So I think in some ways having this experience actually, and particularly if there's good analysis done afterwards about what worked and what didn't work, what the costs were of different strategies, what the benefits were, I think that actually helps us to have a better response next time.
Okay. For the third time, Peter, will you ask my above question about the safety of teachers above in caps?
Oh, so we've done that one now. We've done that one.
Sorry, Andrews.
I saw that. That's why I answered it.
Cherie Wax, aside from overcrowding with tent workers, do you think Singapore has done some things better, e.g. mass temperature taking, isolating COVID cases
Yes,
in separate
absolutely.
hospitals,
Yeah.
enforced versus
So
voluntary.
Singapore's early response was fantastic, and I think a lot of countries, learnt a lot from that. But yeah, it's just unfortunate that, as I was saying before, that these issues of social inequality matter, and so despite having that great early response, now that that benefit is being eroded somewhat by outbreaks in cramped living conditions of temporary workers.
Right. It's interesting, though, isn't it? I mean, just about every Western government, North America, Europe, here, you can point to significant deficiencies in the early response. But if you were to nominate a country that is the nearest to the ideal, you'd have to. The interesting thing about Taiwan is that it's not an autocratic state. It's
not
a liberal democracy. The fact that they were able to achieve what they were able to achieve is particularly significant, I think.
Yeah, but I think too that experience of SARS is important because people remember that,
right,
and people remember being frightened by it, and so people therefore, understand that these viruses, control of these viruses, is important, and are probably more willing to accept measures. Whereas I think, I agree with Sandra that the early response of the government in terms of social distancing was not ideal and was very kind of unclear where, we're going to introduce something but not till Monday, and I'm going to go to the football game over the weekend. Probably wasn't the best way of making it clear to Australians that it was important. But I think, if we'd gone hard initially as well, I don't necessarily think people would have wanted to comply with that and would have agreed with it. I think in some ways, having this restrictions on cafes and restaurants, and I live in the inner west of Sydney, and I can remember that weekend, and cafes and restaurants were packed. There was absolutely no one who was keeping 1.5 meters apart. And for me, seeing that over that weekend, and lots of people saw that, and all the people in the parks. And so then when they brought in the more severe restrictions, I felt people were more accepting of them because they had seen how the other things hadn't worked. Whereas in Taiwan, because they had seen SARS and seen the effect of that, I think they were more frightened. And so the government could come in with these measures earlier on, and the public would accept them. And I think too, it depends on how much trust you have in your government as well. I think as a country, we've lost a lot of trust in our politicians and our institutions, and that makes a difference to how much you are willing to follow advice and accept these measures. So I think that past experience of SARS is a really important factor in why Taiwan had such a great early response.
Right. We're getting I'm just looking, there's a few comments. I don't want to be accused of censoring anyone. Andrus, we better put this up because Andrus doesn't like to be ignored. According to studies, the death rate we raised an interesting claim. The death rate in Wuhan was 16 times more than the regime admitted.
The regime? Yeah. I mean, I haven't seen studies where it's 16 times what they've admitted, so I'm not sure I can comment on that.
Okay, Shuri Wax, can you explain why such high numbers of health workers are dying in countries like US, UK, and Italy?
Yeah, so there's a few factors that are contributing to that. So one is, in those countries, a lot of people are infected. And secondly, the health system has become quite overloaded in some areas, and particularly in the US, there isn't enough what we call PPE, personal protective equipment. So proper masks and gloves and gowns, etc., that you need to use when you're dealing with infected people. And so that, and health workers are clearly at risk because they're dealing with people that are infected with the virus. Sometimes that will be known, sometimes it will be people coming into the hospital very unwell that have not been diagnosed yet. And so they're very at risk of being exposed to the disease. There's also a hypothesis, and I don't think this has been proven, that when you're exposed in that situation, as opposed to, say, touching a surface with your hands and then touching your face, if you're getting the transmission that way, you've probably got quite a small dose of the virus. Whereas if you're in a healthcare setting and you're getting coughed or breathed on in a very small environment, the amount of virus that you get transmitted in that encounter is probably much larger. And it could be that also has an impact on how sick you get. So there's all of those factors that contribute to why healthcare workers in those countries have been so affected. But a really important one is the lack of personal protective equipment. And that's why it's so important as part of this pandemic planning. And Sandra talked about this right at the beginning, of having as part of your plan a stockpile and making sure that you're going to have enough, ramping up production of that like they did in Taiwan, because that keeps your healthcare workers safe.
Okay, we've got a series of questions about WHO. Andrus again. What do you think about Trump stopping the contributions to WHO?
Yeah.
I'll just run them through. Barking Madeline, do you mean President Trump? Mulan. How does Dr. Stanaway rate whose performance in the epidemic?
Yeah. I was about to say that first. I mean, whilst particularly in the early stages, WHO could perhaps have done a better job. I think cutting funding to the WHO in the middle of a global pandemic is not the best move. We need that organisation to try and help us, and particularly in countries that are resource poor. I think having the World Health Organization to provide advice is essential. So, not great.
Although,
Peter, the question was asked of me as well. I just think he's being his normal self. Propriety forbids me from using the actual language I'd like to use. He knows he's buggered it up. He knows that he got it wrong. He's deflecting and attacking in the hope that he can still be re-elected. It's just the act of a complete bastard.
Well, I'm no fan of Trump, but I have sympathy for his what he's done about the WHO. I mean, quite frankly, that guy who had Tedros, I mean, he'd be in a better position if he was a bit less of a ventriloquist doll for the Chinese regime. I mean, the fact he backed them up in their claims that in mid-January that there was no evidence of person-to-person transmission. The regime was claiming that, and he echoed it.
Yeah.
But the last straw, I think, was this support on reopening the wet markets. So, anyway, that's my two bobs on that one.
And in a way, Trump has made that worse, because the reason why the WHO is like that is they get a lot of funding from China. And by the USA cutting their funding, they will now make China the main funder of the WHO. So it's not. So although it's quite right to criticise some of the early response of the WHO, cutting funding, I don't think is the best way to deal with that.
All right. Anyway, we'll plough on. What do we do? Reflections as a health worker. By the way, I think you've been going for nearly an hour and a half. I think we'll have to wind it up. Sorry, we shouldn't persecute you like this. As a health worker, I'm struggling with harms occurring because health system has shifted focus so profoundly to COVID. Fiona, your thoughts on this?
Yeah, absolutely. And it's not even just what the health system is doing. It's what patients are doing. So a lot of people are, skipping appointments, not having regular checkups because they're frightened of going to a doctor's surgery or a hospital where there might be people infected. And that, is likely to have important implications on management of chronic disease. So yeah, absolutely, it's hard what's happening in the hospital system. And that may change. I mean, there's already signs that they may be reopening up some elective surgery because the cases seem to be reasonably under control in Australia. You know, I guess that the approach that they've used is really around trying to, even though it has had impact on the health system, I agree, it's about trying to avoid an even worse impact. So it's about trying to avoid a situation where the health system is overwhelmed by all these people with severe pneumonia that they can't manage. And so that's why they've tried to free up hospital beds, make ICUs bigger, get more ventilators, etc. So that, and whilst, yeah, absolutely that's not ideal, it's really about trying to avoid worse outcomes if we have this massive peak in infections that then results in a peak in deaths. If it seems like that is not going to happen in Australia because we've managed to, I guess the term that everyone uses, flatten the curve so effectively, then perhaps some of those changes in the health system might start to be wound back.
Okay, well, look, we've still got questions in the chat stream, but I think, frankly, we must terminate at some point. We've been going an hour and a half, and Fiona's done a terrific job. Thank you, Fiona. That was fantastic.
You're very welcome.
And thank you, Sandra, for being your usual obstreperous self.
Oh.
I'm joking.
It's all right. We've known each other.
Don't worry, we've been winding each other up for the last 40 years. So it's been a terrific session, and I think we've canvassed an awful lot of issues, and we've actually held our audience quite well. I think we got up to about 125, and we're still 22. So people are obviously very interested in this. I apologise to anybody on the chat stream we haven't got to. This is not political censorship, okay? It's just that we've run out of time. So with that, I think we'll end the broadcast. So thank you very much, and there'll be another one in a week's time on something completely different, something philosophical. We're talking about Heidegger and freedom, and, you know, a bit of a contrast to today. Thank you all for your participation.
Thank you for organising it, Peter.